Welcome to the shoulder girdle lecture. What we're going to do is do this in two parts. We'll start with the shoulder girdle first and then move to the actual shoulder joint in part two. So let's start by looking at the three bones that make up the shoulder girdle. So you can see here we have the scapula, the clavicle, and the sternum, and these are the pieces that fit together to form the shoulder girdle. What we'll see as we move forward are which pieces actually articulate and form the joints, and which structures uh, move as we move the shoulder joint. But while we're on this view, what I want to show you is just a few of the main landmarks that you'll have to identify later. On the clavicle, this broader end here is the acromial end, which ends up being the most lateral part of the clavicle. The smaller end on this side is the sternal end, and this is the more medial side. There are a few structures that we're going to be able to palpate on the scapula. So as we look at it in this direction, we're looking at it in an anterior to posterior view. So here we have the coracoid process. This landmark is probably too deep to palpate comfortably on any person unless they're really thin. This one is going to be a really painful structure to palpate, so we rarely have to worry about that. However, when you've got a patient positioned in prone, you are able to palpate this vertebral border or medial border of the scapula. In fact, you're going to use it often in MMT to make sure that you are palpating the correct muscles. On this end here, we have the acromion, and this is a flat, broad end that can be easily palpated on most folks. We will certainly use this landmark in palpating for goniometry. And then off of this acromion complex, or acromion process rather, we have a broad spine of the scapula, and this is easily palpated as well on most folks. If they're lying prone, you're able to get to this spine of the scapula. The sternum over here on the far right is fairly easily to palpate on most everybody. It's right over the chest. It's superficial because it is protecting all the internal organs. So let's take a quick look at these same structures on a cadaver. As you can see here, these arrows are indicating some of the landmarks we just talked about. This one back here is the spine of the scapula. This is one that's very easily palpated in a prone lying position. This arrow here is pointing at the acromion process. It's that flat end. Again, very easy to palpate on most folks. And then the clavicle, of course, running through here. That's the sternal end on this end, and we have the acromial end over here, and then the sternum right through the middle of the chest wall. So now let's talk about some of these pieces and how they fit together. So there are four articulations with this shoulder girdle. The first is the sternum and the clavicle, and that is your sternoclavicular joint. The sternoclavicular joint is made up of the sternal end of the clavicle, which is the medial end, and the clavicular facet of the sternum. So these two pieces make up your sternoclavicular joint. It's the most proximal joint of the shoulder complex, and it is the only articulation to the axial skeleton for the upper extremities. And I'll show you an image of that just momentarily. The AC joint is the scapula and the clavicle. It's the acromial end of the clavicle with the acromion process of the scapula. The scapula and the thorax forms the scapulothoracic joint. And this is also a unique joint that we're going to talk about momentarily. And then finally we have the glenohumeral joint, which is the scapula and the humerus, and this is your actual shoulder joint. So these are the four articulations of the shoulder complex. The first three, the SC, AC, and ST, are typically considered the shoulder girdle joints and the glenohumeral joint the shoulder joint. So the blue outline is the axial skeleton, and you'll see this arrow pointing to the sternoclavicular joint. This is the only joint, this joint is the only articulation between the axial skeleton and the upper extremity. So in other words, if it wasn't for this joint, there would be no bony connections between your arms and the axial skeleton. So it's a very important joint, and it's one that is a very strong joint, obviously, because of what it's holding up. Alright, so let's start with the sternoclavicular joint. Again, this is the sternal end of the clavicle with the clavicular facet of the sternum, the most proximal joint. The stability for this joint comes from three strong ligaments and one articular disc. This first ligament is the costoclavicular ligament, and as the name implies, it runs from rib 1 to the clavicle. So here is rib 1 and here is your clavicle, and this ligament keeps the two together. It makes sure that the clavicle doesn't elevate too much. The second ligament to show everybody is the sternoclavicular ligament. This ligament travels from the sternum to the clavicle, and it firmly attaches these two pieces in this direction here. This is a ligament that encloses the joint capsule of the sternoclavicular joint. The next ligament is the interclavicular ligament. This ligament connects the medial ends of both clavicles, so you'll see it running through here, and this is a ligament that ensures that they don't separate too far, and it spans across the jugular notch. And then finally we have an articular disc. This disc here sits between the sternal end of the clavicle and the sternum, and if you'll notice, these surfaces are not shaped very closely in size. So the articular disc serves to help improve congruency as it does in most every other joint where you find one. It increases the surface area and helps shock absorption for this particular joint. Let me go back one slide here for a moment. So again, here are your ligaments and the articular disc. But I want to also mention that this joint does move. In fact, it moves a lot, as we'll see in a little bit. This is a gliding joint. It doesn't have movement in any particular plane, but it does elevate and depress. It protracts, retracts, and it rotates. And all these motions are necessary for you to have normal shoulder movement, because it guides the scapula, and the scapula is part of shoulder movement. So this joint does contribute significantly to the motion of your shoulder joint. So here you see an illustration of an SC joint that was dislocated. So this can happen. However, it's going to involve some very significant trauma. But as you can see through an overhead view, a posterior dislocation is a much more significant issue because of all the soft tissue and organs that fall right behind that area. That could be potentially problematic. So these ligaments are all very strong, or stronger rather, on the anterior side of the joint, so that this doesn't happen. You might get an anterior dislocation here and there simply because the posterior side of the ligaments that support this joint aren't as strong, but typically this joint does not dislocate very often. Okay, let's move on to the acromioclavicular joint. So this joint, again, is where the clavicle and the scapula meet, but more specifically the acromial end of the clavicle and the acromion of the scapula. So what holds this joint together? Let's start at the top. Here we have the acromioclavicular ligament. And again, as the name implies, it joins the acromion process and the clavicle together. There are superior and inferior portions of this ligament, but both serve to keep the clavicle and the acromion together. Here we have the coracoclavicular ligament. This ligament comes in two pieces. This first arrow here is showing you the conoid portion of the ligament, C-O-N-O-I-D, conoid. And this part is the trapezoid, but together they are the coracoclavicular ligament. The conoid portion is the most medial, and the trapezoid is the most lateral. This joint also has an incomplete disc that is between the acromion and the clavicle, but because this joint does not move very much, it's not as important that the congruency is there. This is a gliding joint, but it doesn't move as nearly as much as the sternoclavicular joint does. So there is an incomplete articular disc between the clavicle and the acromion. And then the last structure that adds to stability is the deltoid and the upper trapezius attachment. These two muscles help stabilize this particular joint, and I'll mention how that happens momentarily as we move a little further on. Let me give you a quick cadaver look at these same ligaments. Again, you can see the conoid is the more medial portion of the coracoclavicular, seen here. Here's your trapezoid ligament. The coracoid process is under all this fibrous tissue, and that's where these ligaments attach. When this particular joint is injured, you see what's called a step deformity. And you can see why it's called a step deformity. There's this big gap right through here, like a little step. So let me show the x-ray for this. The blue lines indicate where the clavicle is currently. The yellow lines indicate where the clavicle should be. So when there is an injury to the acromioclavicular joint, there's ligamentous damage, like a ligament tear, then the clavicle can no longer be seated next to the acromion. It moves up, as you see here. And it's that movement of the clavicle that gives this step deformity here. So that's typically what you'll see when there's an injury to the acromioclavicular joint. Here we have the scapulothoracic joint. So this is the scapula against the posterior lateral wall of the thorax. So this joint, or the scapula rather, is located approximately between the second and the seventh ribs, but there is a little variation between persons. But that's how you can identify that it's roughly in the correct position. It's posterior, slightly lateral, and between ribs 2 through 7. Now this is not a true joint because there are no ligaments that attach the scapula to the thorax. There is no joint capsule. There is no sensory proprioception from this joint. So it's referred to as a functional joint. Really, it's just a point of contact between the scapula and the thorax. However, it is very crucial to shoulder range of motion. So what do you think holds this joint in place? I'm going to ask you that question, and then you let me know what you think in class. Now the motions that are allowed here are elevation of the scapula, depression of the scapula, protraction, and retraction. So elevation is what you see when you shrug your shoulders. Your scapula moves superiorly. And depression is just the opposite. When you bring your shoulders back down, you move the scapula through depression. Protraction and retraction are actually combinations of movements. Protraction is upward rotation plus abduction of the scapula. So when you go to hug somebody, what you've done is you protracted your scapula. They moved away from midline and they've also upwardly rotated. Retraction then is the opposite. This is downward rotation plus a deduction of the scapula. So this is what occurs when you squeeze your shoulder blades together and reach, sort of like you're doing a row at the gym. So let's see what that looks like here on a skeleton. I'm going to mute that guy. So there's elevation and there's depression, and there is a abduction, and a deduction would simply be moving back towards the midline. So up and out. Okay. Now I am going to let this video play a little bit because it's very interesting to see all the pieces moving together.
As we've seen, the medial end of the clavicle articulates with the sternum at the sternoclavicular joint. Strong ligaments between the clavicle and the sternum, and between the clavicle and the underlying first rib, keep the two bones together, but permit an impressive range of motion. Up and down, and backward and forward. As we've seen, the medial end of the clavicle.
Okay, so what's important to notice is that sternoclavicular joint, and just notice how much movement, even though it's got some strong attachments, just look at how much it allows that clavicle to raise up and down. It also allows it to rotate and to retract and protract. So there's an impressive amount of movement there, and it is very necessary for the shoulder to have normal movement. So let's come back to the scapula for a moment, and what we have here are just diagrams that are analogous to your scapula, and let's see what these different movements are. So when you shrug, you go through elevation. When you come back down, you go through depression. When the shoulder blades come towards the midline, you have a deduction, and when they move away, you have a abduction. Now, rotation, this is upward rotation, and one good way to gauge this is the way that I think it's the easiest is to look to use the glenoid fossa as the reference. So the articulation, the glenoid fossa is the socket for the ball and socket joint of the shoulder, and it's located right through here if you can imagine the actual bone. So when the glenoid fossa moves up, you've gone through upward rotation, and when it points down, you've gone through downward rotation. So let's take a look at that again.
And the scapula move relative to the trunk. Upward movement of the scapula is called elevation. Downward movement is called depression. Forward movement around the trunk is called protraction. The opposite movement is retraction. This movement is called upward rotation. The opposite movement is downward rotation. How the clavicle and the scapula.
Okay, so again, you're able to see the different directions. There's the shrug, and there's coming back out of that. Incidentally, you might want to notice what the muscles are doing as these motions are occurring. If a muscle is if a muscle is shortening, then it's probably doing some of that work. And if they are, let's start again here with a good view. If they're stretching, then they're probably not contributing to the motion. And you'll see as they move through abduction which muscles here are stretching, so you know that these aren't involved in that motion. They have to shorten like this to be involved. Alright, so there are some abnormal positions of the scapula. The first one and the more common one is called scapular winging. So it's important to note that this is only considered abnormal if having this condition contributes to abnormal shoulder movements. So most everybody in class, in your class, can make their scapula wing, and we'll probably do something like this in class. So Just the fact that you can wing doesn't make this abnormal. It's only abnormal if it prevents normal shoulder movement. Winging is when the medial border of the scapula moves posteriorly. Of course, you can see it right through here. The most common cause of this is a weak serratus anterior muscle. So any injury to the long thoracic nerve, which is the innervation for the serratus anterior, can cause this appearance of the scapula, winging. The other two that you don't see very often are anterior or forward tilt and posterior or backward tilt. In an anterior tilt, the coracoid process moves superiorly and forward. And in a posterior or backward tilt, the coracoid process moves inferiorly and posteriorly. So the functions then of the shoulder girdle really are to keep your arm hooked to your skeleton, right, as in the SC joint. But together the SC joint and the AC joint allow full range of motion by guiding the movements of the scapula. So without these two joints, the scapula doesn't move. And without movement of the scapula, your shoulder is going to be very limited in range of motion. The scapulothoracic joint, this also glides and rotates as you move overhead. So without having normal scapulothoracic movement, you're going to be very limited in overhead movements. Let's move on to the glenohumeral joint. So this joint is made up of the head of the humerus and the glenoid fossa of the scapula. This joint provides a tremendous amount of mobility. It's one of the most mobile joints that we have. But when you have increased movement, you have to give up something, and that's stability. So yes, it does move a lot, as we'll talk about, and it's very important as to why this movement is allowed. There's got to be a very delicate balance between the amount of mobility allowed and some stability. But certainly, with this joint, it's so mobile that you do have to give up some stability. Now, what I want to show you here, let me mute this, is an example of a very mobile shoulder. So just look at what she can do. Just simply sitting there, she can dislocate that humeral head from the glenoid fossa. You can see it happening right there. So there's her humeral head moving off of the glenoid fossa. Now this is something that she figured out she can do quite easily on command. So would this be considered something abnormal? Well, for her, this is quite normal. This is normal mobility, a lot of mobility, but it's bilateral, so she can do this with both shoulders, as you'll see here. Now, that would be problematic if it only happened on one side, but as you can clearly see, it happens on both. So this is a lot of mobility at this joint, and one more, just in case you didn't have enough. Make sure you get it at all views. All right. So all this movement, we still need some way to keep the shoulder in place, or we couldn't reach because we'd have fears of subluxations, right? That when the humeral head would come off of the glenoid fossa. And of course, that's not very functional. We can't just reach and then all of a sudden have a dislocation of the shoulder joint. But you want to think of the shoulder joint kind of like this golf tee here. Maybe positioned like this, though. The tee is our scapula, the glenoid fossa, and the golf ball represents the head of the humerus. It actually is much bigger. The ball is much bigger than the socket that it has to fit on, and actually is a pretty good analogy of what's happening at the shoulder. So let's take a look here at a actual bone. So here you have the red arrow on the left pointing at the glenoid fossa, and the red arrow on the right pointing at the head of the humerus, you can see how shallow that socket is compared to the head that's going to articulate with that. So if you think about the hip, there's a very big difference. Even though it's the same joint and moves in the same manner, there's a very big difference in how the pieces fit together. And that's simply because of the function that is required at the upper extremities that isn't necessary for the lower extremities. So here's a cadaver view of the head of the humerus sitting on a labrum. And for comparison, here is the hip joint. So look at that deep socket for that femoral head to fit in. It's a very nice fit, very stable fit, and it's of course reinforced by very strong ligaments. So the difference then is mainly because of the difference in function. The hip joint is a load-bearing joint. It has to be able to handle lots of forces. The upper extremity doesn't. It has to be able to move and reach and manipulate the environment. So you'll see the difference in that when you see the two joints together. Again, another view, with this time with the joint capsule covering the shoulder joint. I want to show you another cadaver video because it's very difficult, I think, for lots of people to really picture what a joint capsule is and how it looks. And on the shoulder, because it's not quite as fibrous, or rather it's not quite as blended into the ligaments, it's a little easier to see. So let's watch this. Oh, my bad, it's not a video. So you'll see the guy holding the tweezers here pulling up on the joint capsule. So in the shoulder joint, the joint capsule has to be a little bit more loose so that the shoulder can move in its various positions. So here you see how the joint capsule can be pulled off of the joint. And it's a pretty good illustration of what a joint capsule looks like. I think this is the video.
Together, it's quite a weak structure. What it does is to permit movement. The structures which hold the two bones together are muscles. Together, it's quite a weak structure.
So you can see here how the capsule is got very slack. It gets very slack depending on the movement of the shoulder joint. So right through here is a good example of the joint capsule allowing mobility. When it moves in other directions, it has to be able to get taut to provide some stability. All right, so speaking of stability, let's talk about the structures that contribute to stability of the shoulder joint. The most important by far is the rotator cuff, and we're going to talk about this separately. But the rotator cuff is made up of these four muscles: the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. If you keep them in that order and take the first letter from each of the muscles, it spells out sits, and so that might be an easy way to help you remember. But these four muscles make up the rotator cuff and are the #1 contributor to stability of the shoulder joint. And we'll talk about those separately. Let's start next with the ligaments of the shoulder joint. We have the superior, middle, and inferior glenohumeral ligaments. The superior ligament gets tight when you move through full adduction and also with inferior and posterior translation of the humerus. With the middle glenohumeral ligament, this gets tight with anterior translation of the humerus and with external rotation of the joint. And finally, we have the inferior glenohumeral ligament. This actually is made up of 3 parts: an anterior band, a posterior band, and what is referred to as the axillary pouch. And that's the easiest to see here. This sagging part right down here is the axillary pouch. The anterior band of this ligament gets tight with abduction and external rotation. The posterior band with abduction and internal rotation. And the axillary pouch doesn't get tight until you've reached 90 degrees of abduction, and then at that point it tightens as you move through more abduction. These ligaments are intracapsular ligaments, so there is a joint capsule around them, and they blend together at the bone, and the rotator cuff comes and blends with these attachments as well. The next ligament that we want to talk about is the coracohumeral ligament. This comes from the coracoid process and attaches on the humerus. This ligament becomes tight with extreme ranges of external rotation, flexion, and extension, or when the humeral head is moved inferiorly, inferior translation. The next structure is the long head of the biceps. So you'll see it through here. The long head of the biceps originates at the supraglenoid tubercle up here, and it becomes a partial extension of the glenoid labrum. And so because it's part of the labrum, it has to contribute to some of the stability of the shoulder joint. If you notice here, you'll see the glenoid labrum. It's this fibrous tissue that is on the outside of the fossa, the glenoid fossa. The labrum helps contribute to stability almost the same way an articular disc does. It increases the overall depth of the glenoid fossa by about 50%. So it gives it a deeper socket for the humeral head to fit against. It adds to the concave features of the glenoid fossa. So here you go with the long head of the biceps tendon that runs down into the arm. As it moves up through here, it becomes part of the glenoid labrum, and that glenoid labrum deepens the fossa here so that there's a better fit between the head of the humerus and the glenoid fossa. And you can see a cutaway of this here. All right, there's one more way that your shoulder is given stability. There are superior capsular structures like the coracohumeral ligament, the upper trapezius muscles, things that sit on top of the shoulder that prevent the girdle from falling into inferiorly, like depression. So when you're standing normally, like say in the anatomic position, your arm is at your side and gravity is pulling down. So the angles of these ligaments and of the upper trapezius don't pull straight up, they pull towards midline. And the force of gravity on the arm is pulling straight down. So what this gives you is a force vector that is somewhere in the middle, and what ends up happening is the head of the humerus is seated more firmly against the glenoid fossa because these two vectors are causing a compressive locking force. Alright, so here is a picture of the rotator cuff muscles on a cadaver. What you're seeing here is the infraspinatus muscle. Here is the spine of the scapula. So there's the spine as it moves to the acromion over here. So on the top side of this spine, you'll find the supraspinatus muscle. The teres minor is a rotator cuff muscle that comes off the posterior side and attaches onto the humerus, not to be confused with the bigger teres major that is sitting down or lower than the teres minor. Again, here are the infraspinatus and the teres minor, and you'll see how these muscles blend in with all the other structures that are stabilizing the shoulder joint through the capsule. Last muscle is this, this is the supraspinatus. This is the muscle that sits on top of the spine of the scapula. It'll come here and slide underneath this acromion and insert on the humerus here at the tubercle, the greater tubercle. So you'll see here where the supraspinatus fits. Let's do the same for the infraspinatus and the teres minor. Here you go with the infraspinatus. It takes up the majority of the infraspinous fossa of the scapula, attaches here on the greater tubercle of the humerus. Teres minor takes up the lower part of the infraspinous fossa and attaches here on the tubercle. The only one we haven't seen yet is the subscapularis. So what you have here is an anterior view of the shoulder. The subscapularis takes up the entire anterior portion of the scapula, and it attaches on the humerus as well. You'll be able to see that here. It sits here and attaches on this side of the tubercle. Quick video.
Scapularis, supraspinatus, infraspinatus, and teres minor converge on the humerus to form an almost continuous cuff of flat supporting tendons, often referred to as the rotator cuff.
So here are the motions that are allowed by the glenohumeral joint. In the sagittal plane, just like with the hip, we have flexion extension, frontal plane, abduction, adduction, transverse plane, external rotation, internal rotation, and we can add now horizontal abduction and horizontal adduction. These are two movements that we could not replicate at the hip joint. Circumduction, like at the hip, is simply moving through flexion. As you try to bring your arm all the way behind you, you have to move out into abduction and external rotation, and then you can complete somewhat of a circle coming back to your midline. Function. Now, these joints allow these movements in these planes, but rarely do we ever move in strict planes, especially with the upper extremity. You have to be able to cross multiple planes to be able to manipulate the environment. So for the upper extremity, really the functional movements cross all these planes all the time. And when we rehab folks, we're trying to certainly work on muscles that move the joints in straight planes, but at some point you have to incorporate the functional aspect, which is making the person reach through multiple planes. Now, I think we're going to cut here with part 1, and then we'll pick up with part 2 at the scapulohumeral rhythm.